Hi everyone, this is Dr. Souchard with a presentation about the use of carnitine as an antidote. Carnitine is not a very commonly used drug in acute care settings, and as we'll see, it's virtually only used as an antidote for valproic acid toxicity. The objectives for this presentation are that when you're finished with the video and studying any related course materials, you should be able to describe carnitine's structure and function in normal cellular metabolism, explain why carnitine is considered an antidote for valproic acid toxicity, and provide a dosing regimen for carnitine when used for this indication. With regard to its structure, we see here that carnitine is an amino acid, but unlike the list of 20 amino acids you probably learned about in your biochemistry courses, carnitine is not one of the essential amino acids. This means that we humans are able to synthesize our own carnitine in addition to getting it from dietary sources. Now, there are some rare genetic disorders where a person can't synthesize carnitine endogenously, and these people will need treatment with carnitine supplementation. And we also see here that there is a chiral carbon in carnitine, such that there can be L or D stereoisomers, and it's the L stereoisomer that's the biologically active one. Okay then, but what's carnitine for? What is its role in metabolism? We all know glycolysis pretty well, where the body gets energy, or ATP, from carbohydrate metabolism. But what about fat? Carnitine helps fatty acids get into the mitochondrial matrix, where they are metabolized through a process called beta-oxidation to provide energy. This is a pretty slick mechanism where there is a carnitine shuttle that goes back and forth across the inner mitochondrial membrane, picking up a fatty acid on one side and depositing it on the other without being used up. In the upper left, we see a fatty acid in the cytosol, and it can't cross membranes to get into the matrix by itself. The fatty acid is first esterified, or covalently bound, to coenzyme A, making a fatty acyl-CoA. Carnitine comes along and takes the place of coenzyme A in a trans-esterification reaction catalyzed by carnitine acyltransferase 1, producing fatty acyl-carnitine. And another molecule of free carnitine from inside the mitochondrial matrix then gets exchanged through a transporter channel for the acyl-carnitine in the intermembrane space. The net result is that the fatty acid, or fatty acyl group, is now inside the matrix, and the carnitine molecule that shuttled it has now been replaced. There's another trans-esterification reaction catalyzed by carnitine acyltransferase 2, recreating the fatty acyl-CoA, which can then undergo beta-oxidation. With regard to fat metabolism, in the previous slide we'd already skipped a step. The first step in fat metabolism is to break apart fat, or lipolysis. Fats are triacylglycerols, which are hydrolyzed by lipases into 3 free fatty acids and a molecule of glycerol, a 3-carbon sugar. Then we do the whole carnitine shuttle to transport those fatty acids as acyl groups into the mitochondria. In the mitochondria, the fatty acids are broken down into multiple units of acetyl-CoA, and this process is called beta-oxidation. We start at the upper left with a fatty acyl coenzyme A molecule. The first carbon away from the functional group in the fatty acid is the alpha carbon, and the second carbon over is the beta carbon, and this beta carbon gets oxidized in a series of reactions, hence it's called beta-oxidation. And we end up with another fatty acyl-CoA, but one that is 2 carbons shorter, because those other 2 carbons now form the acetyl group in a molecule of acetyl-CoA. Then beta-oxidation occurs again and again, each time shortening the fatty acid by 2 carbons and making another acetyl-CoA. Okay, great. So where does the ATP come from once we've made all of this acetyl-CoA? This next part will probably be more familiar. The acetyl-CoA, 2 carbons in the acetyl group, combines with oxaloacetate with 4 carbons, to form citrate as the initial step in the citric acid cycle. We see here that citrate has 3 carboxylic acid groups, which is why the citric acid cycle is also called the tricarboxylic acid, or TCA cycle. And this series of reactions was described by Hans Krebs, which is why we also call it the Krebs cycle, for which he won the Nobel Prize in 1953, which he shared with Fritz Lipmann for discovery of coenzyme A. Each round of the citric acid cycle produces 3 molecules of NADH, 1 molecule of FADH2, and 1 GTP, which is energetically equivalent to ATP. The reduced dinucleotides, NADH and FADH2, feed electrons into the electron transport chain, providing the power to drive oxidative phosphorylation and make ATP. All of this is great. We'd like to continue to be able to metabolize fats, to make acetyl-CoA through beta-oxidation, and all of this is dependent on getting the fatty acyl groups into mitochondria through the carnitine shuttle. If we don't have enough carnitine around, if there's a carnitine deficiency, a metabolic crisis can occur. As you know, the liver is a very metabolically active organ, and it can get very angry in a metabolic crisis. Part of the crisis is that we can't metabolize fat well, and it accumulates abnormally, particularly in liver cells, resulting in microvesicular steatosis, which I'm going to describe in more detail very shortly. The liver gets injured and leaky, so we see elevated liver function tests. And since ATP production is impaired, there can be a metabolic acidosis with elevated lactic acid levels. With carnitine deficiency, we aren't making enough acetyl-CoA, which is necessary to make ketones, so these patients will have low ketone levels. Another marker of impaired fatty acid beta-oxidation is hypoglycemia, which may result in altered mental status. And these patients also typically have elevated serum ammonia levels, which can also produce encephalopathy, since the urea cycle is secondarily inhibited, which we will also see in a bit more detail shortly. We're going to take a very brief one-slide detour to talk about fatty liver, since we've already begun discussing fat metabolism and liver cells. Hepatic steatosis literally means the condition of having a lot of fat in the liver cells, and this can occur along a spectrum. On one side of the spectrum, we can see microvesicular steatosis, where there is an accumulation of fat in multiple small vesicles. The tiny vesicles are spread evenly throughout the cell, so the nucleus remains in the center. On the other end of the spectrum is macrovacuolar hepatic steatosis, which is the more common pattern. This is often benign, and it's the kind associated with ethanol and with obesity. Lots of people can get an ultrasound or CT scan and be told they have a fatty liver, and it's probably just related to excess fat and calorie consumption, as found in a typical yet unhealthy American diet. Here we see a single large fat-filled vacuole, so big that it displaces the nucleus to the cell's rim. Microvesicular steatosis is the peculiar form of fatty liver seen with impaired beta-oxidation of fatty acids. This is a histopathology slide of liver cells, which are normally filled with a nice deep pink staining cytoplasm. The cells here are much lighter staining since they have been filled with lots of unmetabolized fat in small pockets all over the cell. But the fat gets removed in the process of making and staining histology slides, so there's much less material left to get stained, and the cells appear with a lighter, frothier pink than normal. The metabolic crisis of carnitine deficiency, of impaired beta-oxidation, is the same metabolic crisis that occurs in Reye syndrome and in acute fatty liver pregnancy. On the left, we see the first report of Reye syndrome from The Lancet in 1963. Children with viral illnesses treated with aspirin were found to develop fatty degeneration of the viscera, and an encephalopathy associated with elevated serum ammonia levels and hypoglycemia. Reye syndrome and acute fatty liver pregnancy occur because fatty acid beta-oxidation is impaired, although through different etiologies. And this same metabolic crisis also occurs with Jamaican vomiting sickness, one of my favorite toxicologic zebra diseases. There's a toxin called hypoglycin A found in unripe ackee fruit, which impairs beta-oxidation and can, as the name implies, result in altered mental status in part from hypoglycemia. The unripe fruits are red and about the size of an apple. As they mature, the amount of hypoglycin decreases, so they are edible without danger. The fruit splits open to show some large black seeds surrounded by the light, fleshy, edible part which has the consistency of scrambled eggs. Ackee fruit are common in the Caribbean, particularly in Jamaica, where the national dish is ackee and saltfish. Jamaican vomiting sickness, although rare, occurs most commonly in children who know that the ackee is edible, so they pick it off the tree, but they don't know yet why they should wait for it to mature. In fact, the 1963 report by Rye about Reye syndrome very explicitly stated how similar it was to Jamaican vomiting sickness. Some ackee is canned and exported, so there are very rare cases of imported Jamaican vomiting sickness if the canned fruit was not sufficiently ripe. Let's get back to carnitine. Carnitine can be used to treat primary carnitine deficiency syndromes. There's a number of enzymes involved in the carnitine shuttle or in carnitine synthesis or absorption that could be non-functional on a genetic basis. And it's also possible to develop an acquired carnitine deficiency. This slide shows some labels of various carnitine products, with those on the left for IV administration and those on the right for oral supplementation. And now, finally, I want to talk about one particular way to acquire a carnitine deficiency, which is through the drug valproic acid. Valproic acid is commonly used to treat seizures and also as a mood stabilizer. If we take a look at its molecular structure, we see that valproic acid is indeed a short-chain branched fatty acid. And because it's a fatty acid, it's no surprise that it might affect normal fatty acid metabolism. In the lower right, we see the structure of divalproex, which is the formulation of valproic acid most commonly used, because it has favorable physical and pharmacokinetic properties. The di in divalproex means that there are two valproate molecules that are kind of sharing a single sodium ion. Valproic acid, or VPA, interferes at many steps of normal fatty acid metabolism, resulting in carnitine depletion and inhibition of beta-oxidation and the urea cycle. As a fatty acid, VPA can become esterified to carnitine, sequestering the carnitine and lowering intracellular levels, and then some of the VPA carnitine is renally excreted and the carnitine is lost. The VPA carnitine also competes with carnitine, blocking carnitine transport into the cells so that they can become further depleted. The valproic acid that gets transported into the mitochondria using the carnitine shuttle then is metabolized through beta-oxidation, and the metabolites bind to and deplete coenzyme A and further inhibit beta-oxidation. And other VPA metabolites will inhibit the urea cycle. This slide shows a putative model for how valproic acid can result in hyperammonemia. Starting in the upper right, we see again that valproic acid will deplete carnitine, which leads to inhibition of beta-oxidation. Less beta-oxidation results in lower acetyl-CoA levels. Less acetyl-CoA means that less of it gets combined with glutamate to synthesize NAGA, or N-acetyl-glutamic acid. Normally, NAGA combines with ammonia to form carbamoyl phosphate, which then enters the urea cycle, but since there's less NAGA around, less of the ammonia enters the urea cycle, which is the way we normally get rid of nitrogenous wastes. Instead, the ammonia accumulates systemically, and we get hyperammonemia. In fact, hyperammonemia and increased LFTs can occur associated with valproic acid, even in the absence of overt toxicity. With normal VPA dosing, asymptomatic increases in serum ammonia and LFTs can be seen in over a third of patients in their first 3 months of therapy. This is common enough that serial lab monitoring is recommended. And some patients are given supplemental carnitine in an effort to reduce this subclinical toxicity and prevent it from getting worse. That being said, there are plenty of patients on chronic VPA therapy who never develop abnormal labs or symptoms. But what happens with valproic acid overdose? What would acute toxicity look like? Similar to many other anticonvulsants, CNS depression is expected to be the most prominent finding, and the degree of CNS depression roughly correlates with the drug level. And you may or may not also see evidence of the metabolic crisis of beta-oxidation inhibition. So a full set of labs looking for metabolic acidosis, abnormal liver function tests, and ammonia levels should be ordered and followed serially until the acute severe toxicity resolves. So now we're at the stage of administering carnitine as an antidote for valproic acid toxicity. As per the chapter in Goldfrank's Toxicologic Emergencies, L-Carnitine is recommended when valproic acid causes the adverse metabolic effects we've already discussed, namely hyperammonemia, a serum ammonia level of 80 micrograms per deciliter or higher, hepatotoxicity, metabolic acidosis, and/or encephalopathy. Although it's not described whether this encephalopathy has to be hepatic encephalopathy or if the nonspecific CNS depression seen with most anticonvulsant overdoses is sufficient. While optimal carnitine dosing has not been strongly established, the Goldfrank's chapter recommends a high-dose protocol for sicker patients and a lower dose for less sick patients. Patients with severe metabolic crisis are given an IV loading dose of 100 milligrams per kilogram up to 6 grams over 30 minutes, followed by 15 milligrams per kilogram every 6 hours. Less sick patients get 100 milligrams per kilogram per day, up to 3 grams, in divided doses to be given every 8 hours. But if you look at the indications here, that is for overdose without hepatotoxicity or hyperammonemic encephalopathy, it's not clear that such patients even meet the criteria stated for giving carnitine on the previous slide. Oh, and you should also be aware that treatment with carnitine can make the patient, and especially their urine, smell like rotting fish. I haven't encountered this yet in any patient getting carnitine for acute severe valproic acid toxicity, but I have taken care of one patient chronically on carnitine for an inborn error of metabolism, and I can tell you that the smell was quite strong and distinctive. Okay, that's all for now about carnitine's use as an antidote. I'll be seeing you around.